Welcome back to Mayo Clinic Radio. I'm Dr. Jake Strand.
And I'm Tracy McRae.
A rapid response team is a group of critical care specialists available to rush to the bedside of any patient who may be heading for trouble. Rapid response teams can provide timely assessments of hospitalized patients who may need critical care interventions or to be transferred to a higher level of care.
The team often has no prior knowledge of a particular patient and must make a swift assessment of a situation based on a verbal history, the medical record, an examination, vital signs, and any other available information. Here to discuss Mayo Clinic's rapid response teams is Mayo Clinic pulmonologist and critical care specialist, Dr. Alice Gallo. Welcome to the program, Dr. Gallo. It's nice to meet you.
Thank you so much for having me. It's nice to meet you too.
So, Dr. Gallo, what makes up a rapid response team at Mayo Clinic and who's all involved?
So here at Mayo, what makes up the rapid response team is a critical care fellow, a critical care nurse, and a respiratory therapist. There's always a board-certified critical care physician who oversees all the rapid response activations, and we're ready to discuss the cases with the fellows and make sure it also turns into a teaching opportunity.
I'm confused because I'm the layperson here. How is this not just an emergency room or an emergency department? What is the difference here?
That's a very good question. So this team specifically only works in the hospital and takes care of patients who are already admitted to a regular ward. So someone who came in because of a pneumonia, and instead of getting better, they got a little worse. So the primary team needs critical care help at the bedside.
Yeah, I think that's the important distinction, Dr. Gallo, that is tough for a lot of people to understand. So when you think about, people are in the hospital because they're really sick. So what type of patients would get a rapid response team involved?
We help taking care of everybody in the hospital. So someone who came in for a medical problem, someone who came in for a surgery and did do so well after the surgery, any patient who is admitted into the hospital.
So you guys are like, I don't know, it sounds like it's a TV show script ready to roll, the rapid response team.
That's pretty much it. It's a very cool gig.
It is exciting. Do you enjoy your work?
I love my work. I love the fact that we are able to bring help to the bedside, from the ICU to the bedside. And particularly, I love talking to the other teams also. It's a very good collaborative work that I feel it helps the patients a lot.
Yeah, see, that's the piece I'd be curious to hear more about. So, I can see some people saying, well, hey, my team in the hospital knows what's going on best. So how does the rapid response team work with the team who's directing my care already?
So when care is the best is when the primary team is at bedside. So they are the ones who know the patient best, like you just said, and they know the families, they know the backgrounds, they know the patient's specific interests regarding higher level of care. So when we get there, usually the primary team is at bedside. They give us a quick background. Like you said, we have to think on our feet pretty quickly. And with the primary team, we make the decisions.
So the nurse puts up the bat signal and you guys are there just like that. Is this how this works?
We usually get to the bedside in about 3 to 5 minutes average, but we have to be at bedside in 10 minutes.
And so is it just that the nurse, do you guys have pagers? How does that work?
Yeah, that's a very good question. We have a specific rapid response team pager. Anyone can activate the rapid response. So family members, we had instances that patients themselves activated the rapid response team to come to their bedside. Bedside nurse, the primary team, anyone taking care of the patient can call us.
Yeah, so that's great. So we've got pagers now. So what are we changing how that's going to look? Are there other advancements that Mayo Clinic is making when we think about how rapid response teams are deployed?
Right now, we're still using just the pagers. I'm pretty sure with app development and with advancements in medicine and computers, I'm pretty sure we're going to have new things.
So how does this go once the rapid response team then gets on the scene? Everyone else that's in the room steps off to the sides? How do you guys do the handoff?
No, we want everybody in. We want everybody involved. Usually what happens is the critical care fellow would make the first assessment, will go straight to a patient's bedside and talk to the patient. The RRT nurse will get the vital signs, put the patient on a monitor, and the respiratory therapist is there in case it's something related to difficulty breathing or or anything respiratory related. And the primary team usually will tell us what's going on, what's their concern, which is the main piece of information that helps us actually.
So we're really, it sounds like bringing in lots of additional expertise to help surround that patient with an added layer of support while they're already in a tough situation in the hospital.
Yeah.
Okay. So in thinking then, so that all sounds perfect. So does that mean that we've gotten better at patient care or outcomes better for patients who undergo one of these activations?
That's a very tricky question. So at Mayo, we already had the whole purpose of creating rapid response teams was to actually make sure that we get to these patients before they decompensate. That started in 2005.
Wait, what does decompensate mean?
Sorry about that.
That doesn't sound good.
So for patients who are admitted in the hospital, before they get to a point that we can't make them better in terms of they have their heart stops or they stop breathing. The whole purpose was in 2005, it was noticed that several heart attacks in the hospital, cardiac arrests in the hospital, when people's hearts stopped in the hospital, could have been prevented by an extra layer of eyes looking into this patient. So that's when rapid response teams were created, 2005. So what we hoped to do was that extra layer would catch any signs that these patients were leaning towards a not good outcome and make sure that we caught them early to take them to the ICU if they needed, or to make sure that extra interventions were done. So far, we have conflicting data showing that in some hospitals, in some countries, rapid response teams actually improve outcomes, and in some hospitals, in some countries, it doesn't. At Mayo, we had very little cardiac arrests to begin with, even before we started our team, and it's still very little. We do bring a lot of people to the ICU, but outcomes are actually very conflicting.
So that is one of the things that has changed. You are taking patients to the ICU. You are catching that.
Mm-hmm. We're catching that, but we didn't notice a hard improvement in mortality because we had a very low numbers of cardiac arrests to begin with.
Well, certainly getting the right resources to that patient, I imagine, makes families feel better that they have those additional resources available to them. And so I know, certainly having been part of cases where patients really feel glad that there's the ability to get extra support there at a moment's notice.
I've noticed that the primary teams really like us. The bedside nurses really like us. The families really, really like us. And it's what you said. People just feel like the extra layer is very helpful. And it's a fun work.
Well, that's wonderful. We've been talking about rapid response teams with Dr. Alice Gallo, a pulmonologist and critical care specialist at Mayo Clinic. Thanks so much for joining us, Dr. Gallo.
Thank you for having me.